And now we proceed to the final speaker of this session, which is Professor Piet Leroy. I hope I pronounced that correctly. Now, you're a professor in the beautiful town of Maastricht at the Maastricht University, related to procedural sedation and analgesia in children. Now, you are, which you pronounced when I met you before the session, you are a pediatric critical care physician, not a neonatologist. It was important for you to stress that. And as just said, your main research topics are procedural sedation and trauma-free medical care in children. So you're very welcome.
Thank you. Good morning. I find myself in a very critical position right now between two giants and FICA. You see my position. Thank you for the kind introduction. My name is Piet Leroy. You pronounce it in the French way. I have a French background many centuries ago. I'm from Belgium originally, but working as a pediatrician, pediatric critical care specialist in Maastricht in the southeast of the Netherlands. And I'm going to talk to you about from procedural distress to procedural comfort. And I love actually the way you suggested us not to speak too much about pain and fear, but much more about the positive outcomes like wellness. Therefore, I stress on comfort. And we don't speak about no fear, no pain, but much more about trust that we leave as a feeling in children and parents after a meeting during a procedure. I have no conflicts of interest to declare. My work is supported by this society, which is a society of parents, and I'm organizing the biannual conference on procedural comfort, sedation and analgesia in children in Maastricht. So if you want to visit Maastricht this year, this is your unique opportunity. I'll show the slide at the end of my presentation again. So first of all, a warning. I'm not a neonatologist. I don't know anything of the premature baby anymore. So here so I could stop right now, actually. So we go to FICA. I'm a critical care specialist indeed, but my focus is both sedation, analgesia, and medical education. So I'm heavily involved in medical education in students, colleagues, but also parents and children, as I have discovered that when children and parents come to a hospital with a sickness, they are learning all the time. So the real issue we share in common as professionals is that we actually are a learning community, and that the solutions we are looking for when there is uncertainty is always in the educational relationship. So that's why I'm so happy with your comments you made during your lecture. Actually, my fascination for this work started in 1993, when I started my residency in pediatrics, and the first 3 months we spent on the neonatology ward. And there was an intention for that. We had to learn 3 things: blood sampling, catheterization of the umbilicus, and intubation, as quick as possible, so that we could go on transfer in an ambulance to retrieve children. Otherwise, the staff had to do that. So that was actually the main teaching goal in the first 3 months, just learn on these kids these 3 tricks. So each morning, I was asked to puncture the children, because at that moment, each neonate got a blood sampling every morning, sick or not sick. Because there was a fear for infections, inflammation, of course, you can understand, there was a reasonable argument. And I noticed as a very young doctor, I come from a big family, 10 children. I have a loving mother. I've been sick as a child quite often, and I remember that when I was sick, my father and mother were caring for me. I remember the touch of the hand of my father on my face when I was sick, or my mother slowly giving me oral rehydration solution when I was sick. That love. I came on the NICU and there was no love at all. It was a technical, purely mechanical environment. And I was puncturing this kid, squeezing that hand. I saw pain reactions. And what I noticed after like 2-3 days, when I was just touching their hand, that I saw the same reactions even without the needle in it. So I tried to talk about this to my supervisors. That was 1993, and they said, no, you just see reflexes. So that was when I met you, not in person, but with your papers you published at the end of the 80s. And thanks to your papers, actually, I learned that this was really what I was seeing. I saw painful reactions, I saw emotions, I saw distress. So I'm so proud that I'm the speaker after you. So thank you for finally meeting. You were the beginning of my journey in this field. I can really say that. Later on, as a resident, I spent about 2 years on the Pediatric Oncology Unit. Maybe some of you have worked there during their training as well. 1993 to 1998. Oncology was a terrible field to work in. They could save a lot of children already, but the journey to that healing was just one torturing event. The bone marrow punctures without sedation or analgesia, the lumbar punctures, the sequence, the children getting in that room with their anticipating fear, freezing or fighting. It was just actually ignored by the whole team because that was in the best interest of the child. So it was considered, all these procedures, as a necessary evil. It was a part of healing. Without this, we couldn't heal the kid. And actually, there was this Machiavellistic approach, the goal justifies the mean. With a noble goal of healing, we could do anything in a child. And that actually inspired me a lot to focus on this field of procedural distress, and mainly on how to teach professionals in this. This is my focus. I don't need further proof to show with certain complex molecules that painful events cause stress in patients, and I don't need any research to show that if you love them, that it will decrease. That's evidence. That's of course evident. What I'm intrigued by is why it's so difficult to incorporate these findings in our daily practice. So talking about love, there was this question, talking about love, how to teach professionals in loving professionally. That's a real challenge. The evidence is there, but how to teach, how to incorporate it in our busy units. That's my challenge. That's what I'm going to talk about. And we don't talk anymore, fortunately, about the bone marrow punctures and the really heavy procedures. Fortunately, in most hospitals nowadays, these really major procedures, they go under deep sedation or anesthesia. Endoscopy, bone marrow punctures, complex wound care, usually there is a solution for that. But the real challenge in pediatrics is this, what we call minor procedures. It takes just a minute. It's just done quickly. I warn children, when a doctor starts using these words, they should get out of the room. Because that's the way we camouflage what we are doing. It's minor in our perspective, it's absolutely not minor in the mind of a child. Nasogastric tubes, for example, if you look in infants, what happens, about 80% needs to be restrained down to be able to perform the procedure in one of the most vulnerable areas of the body, full of senses. And there's still not a routine, common approach to deal with this. We are finishing a qualitative research in Belgium, the pediatric departments. We asked all the teams, how do you perform this? And it's always different. It's always, there's no routine. We just ignore this field, just put it in. And it's the doctors who give the job to the nurse. It's the nurse who has to do the job. You know Pilatus? From the story, the suffering of Christ, the last few hours of Christ, there was Pilatus who decided, and afterwards he was washing his hands in innocence. That's what's happening. So it's a complex challenge. And just to make it clear, I'm going to share a video. Let's make it clear what's the problem. And I'm going to focus with you on this little finger here. You will not see this in neonatology, I think, this kind of wounds, but this is the finger of a hand of a boy, 8 years old. His finger was between the door of the car. They were on their way to whatever, together with his father. So this is a minor wound. It needs only a few stitches, just a minor needle in the finger to take the pain away. So it's a simple thing. They come in a busy emergency room, and there's the finger. Okay, let's have a look for 1 minute between the arrival of the child and what the medical team is going to do. By the way, this comes from a television program, from a Danish television program, but it could have been filmed in any of our hospitals. So first of all, I have nothing against Denmark. I love Copenhagen a lot. So don't focus on where it comes from. But the nice thing is this was filmed in one of these documentaries that we have all over the place to show how good medicine is. Do you have that in your country as well? That you want to show to the community, look how successful we are. So that we allow camera teams in our hospitals and journalists and they show, wow, these are heroes. That's the program this comes out. So be sure that this has been screened by the communication department of the hospital and by everyone involved in the video. This is not a hidden camera. Are you ready for the movie? Yeah? There's no neonate. You will not see a neonate. So be ready. Okay. So here's the finger again.
Umiddelbart om knoglen skal være skadet der, så vi skal have taget et røntgenbillede, når vi er færdige.
Jeg tror ikke, vi kommer udenom, at det skal syes. Nej. Jeg tror godt, vi kan få et pænt resultat, så skal vi bare have en 5-0.
Det vi gør, når vi har kigget på skaden, det er så, at vi skal bedøve fingeren, sådan så at det ikke kommer til at gøre ondt, når vi skal rense og sy den. Men det gør rigtig ondt at få lagt sådan en fingerbedøvelse.
Det bliver vi nødt til.
Ja, kom. Han prøver også at aflede og berolige drengen hele vejen. Marius.
Prøv lige her.
Marius. Prøv lige at høre her. Prøv lige at kigge på mig en gang. Prøv at se, nu sætter far sig med dig op på sengen. Jeg holder bare din ben.
And we stop. I could take an hour to deconstruct this video with you, but I haven't the time. There's Fika after me. But just look back to this final moment here. There are three parties involved: a father, a boy, and a healthcare professional. I believe the nurse is very patient. She's kind, she's smiling, she tries her best. First, a word about empathy. Many people say that we need more empathy in our field. I don't agree. Here on this screen you see there is a high level of empathy between the father and the nurse. You see them smiling, they're matching each other's behavior because they have a common interest. The nurse wants to proceed with the procedure or to assist the doctor, and the father for some reason wants to make it happen quickly. That's an unnatural reaction of that father. If this man would do this in public, somewhere in the street, we would call the police. So showing the complete disturbance in the mind of this man if he is entering a medical room. Here is a complete destruction of the normal relationship between a father and his son. And maybe it was the father who closed the door of the car. Maybe he feels guilty. Maybe he wants to give his son a chance to go to the football match they were going to, whatever. This is the complex setting I'm talking about. This team here is highly trained in performing a suture in a finger. This is a team that actually would like that only the finger gets in the room and that the patient waits in the waiting room. That's actually what you see. They are ready, they know what to do about the anesthesia, the needle, they are perfect. But the problem is there is a child attached to the finger. And so look here. This boy, he's curious. You were talking about curiosity. I come back on curiosity. He's actually holding his father. He's able to hold his arm still. So he has a lot of competence. No one sees the cues that this boy is sending to you about his fear, his sadness, his competencies, his whatever. No one is seeing it. This team is trained in dealing with fingers and not with human beings. And I think that's the real challenge. Even on NICUs, how well are we trained to deal with human beings versus dealing with diseases? That's a question for you. And of course, in pediatrics, these children start to resist. Probably in neonates, the very young ones, can they really resist? No. This boy is restrained. He's at the edge of the age where you still can restrain. If he would have been a 16-year-old boy with a lot of tattoos and piercings, no one would have tried this to do. But young children, they are very vulnerable for being restrained physically. And of course, then the procedure is about to fail. So we use restraint, causes more fear, obviously. So that results in trauma and especially a loss of trust. We know from literature that in chronically sick children, 15 to 20% suffer from severe post-traumatic stress disorder up to 5 years after disease. But what is even more important, up to 30% of parents of these children suffer of the same problem. Parents suffer on the long term more than the kids. And these are the parents that have to educate the children, comfort them for the next meeting. So that's the consequence of what we cause in these children. Loss of trust is a real issue. And you know, I've been here in the last 3 days lecturing together with my friend Baruch Kraus in the hospitals here. I'm here since Sunday evening. And we have seen that in the hospitals here, the toolbox is completely full. We have a lot of tools here, all tools for taking pain and fear away. I'll show you a few. We have the topical anesthesia. We have the Buzzy. Do you know the Buzzy? It's a vibrating tool that makes use of the gate control theory that actually is a tactile stimulus together with distraction, playfulness, and together it might decrease the pain of simple needle procedures. We've seen them in the hospitals. They are play therapists who can play with children. Play. We were talking about play. Play is crucial. Any one of you has had training in playing during your professional training? I'll come back on that. So we have people trained in hypnosis. This is a hypnotic situation during a CT scan or during another kind of imaging. We have these virtual reality goggles. Everybody's now buying virtual reality goggles because that's technology. Wow, great machine, modern. Let's buy this. It will solve our problems. We have nitrous oxide, for example, sedation. In the hospitals here, there are everywhere these magic walls, beautiful color, interactive, great, child-friendly. Or we could use deep sedation in cases of severe major procedures. So the toolbox is full. And yet, the suffering is all over the place. I met nurses who told me, yeah, I put amla on, but it's not working. I asked, yeah, why is it not working? What's happening? Yeah, we just put amla on. Yeah, but what do you say when you put amla on? Do you build trust when you put amla on? Or is it just a mechanical, formulaic way of, oh yeah, we had to put amla on? Or we take the iPad. Oh yeah, the iPad is going to distract the child. Here's the iPad. iPad is not going to do anything. It's about the relationship you get thanks to the iPad. So imagine this girl comes. What to choose? Oh, let's make a protocol. Oh, but you cannot protocolize personalities. That's impossible. So here we are with all our protocols who help us to deal with pneumonia and asthma and meningitis. That's protocol. But now we suddenly have to deal with a human being and build relationships. And actually, it turns out, if we look in our curricula, that that's actually absent in our training programs, how to do that. And it's a field of uncertainty, because this kid might trust you after half an hour, but maybe within a week something happened and she trusts you not anymore. So we cannot predict easily. Today is the 21st of March. That's International Down Syndrome Day. I hope you all have 2 different socks on. You have? I haven't, but that's normally the symbol of celebrating International Down Syndrome. But this kid, if she comes, what does she now need out of the toolbox? Wow, completely different challenge. Or this boy with spastic tetraplegia. If you start puncturing him in his elbow, he will be more spastic. So it's a completely different approach you need. So the Buzzy or the AMLA will maybe not work like you wish. Or this little boy with a suspicion of autism. Wow. Here's your unique chance to damage the child forever. So if we put them in their routine processes in our hospitals, we cause a problem. Or this little baby, which is more closer to yours. We see in our pediatric community a lot of formerly premature babies who have been treated in your units and who don't trust anyone. I don't know, I'm not for sure that this is caused in the children, but very often we see very stressed parents who are not able to regulate each other. So, wow, that's a huge responsibility you have with these vulnerable children you're dealing with. And I'm collecting vaccination pictures. That's one of my hobbies. But just look, what is common on these pictures is, what is always the same is the needle and the vaccination. It's always the same. So training professionals in vaccination is very simple. It's a needle in an arm and then inject. But just look to the different reactions. Some of them have no problem at all. Come on, give me another shot. I come back tomorrow. I will be vaccinated all my life. This boy is self-hypnotic, in a self-hypnotic state. And he was smart enough to bring his own system with him. But imagine that he had forgotten. What should you do? This is a funny girl, but she still needs help. She's suffering a bit. He's restrained. He as well. Look to this guy. And this girl. So all different reactions. So it is not a matter of organize a protocol for vaccination. What's missing here is who is trained in reading the child, or this child needs to do it well. And there's another partner involved. So sometimes, as you know, this is a diet or a triad. It's not the child only. There is a mother, a father, and many pediatricians suffer, or nurses suffer, of the parent. It's the parent who is the problem. It's the parent who doesn't understand. It's the parent who says, come on, proceed, move on, we are in a hurry, or it's the parent who whatever. But how to deal with her anxiety? Many children we see in our units actually have anxiety because their parents have needle fear. That's a epigenetic, whatever, but it's proof for that actually when parents are damaged by medicine, they will have children who have fear in medicine. So there is our unique chance to interrupt that cycle. And I want to dive a little bit deeper in this picture here. Okay, here's the picture. I wouldn't advise you to do vaccination in this way. See, by the way, again, the empathic mismatch here. If I come home, I will meet my wife tomorrow in Paris. Yeah, we'll meet in Paris. That's I will look forward to it. But imagine that my wife looks like this and I respond like this. You could imagine that we have immediately an emotional mismatch between the two of us. But this is what we show all the time. We don't match with our patients. But the interesting thing on this picture is actually on the background. So what do you think this child is going to believe when she's on this chair now and we say, don't worry? How have you organized medicine in pediatric wards? When children come in the ward, they hear screaming the other kids. So think about the setting we are working in. In neonatology, of course, maybe these infants are not hearing this, maybe screaming is much less in your setting, but still, children learn continuously. This kid here is learning, she's watching. What's happening there? Do we take that into account? No, we don't. And so this is the result. This is the result in my field. That children, after a certain while, they escape. Probably you have never seen this in your hospital, that a neonate goes there. I hope it's not the case. By the way, I always have to say that this is not in my hospital. Because before you start thinking, wow, this looks like a little bit not really Dutch, but it's not. But there are actually two victims here in this room. Of course, this guy here, there's this guy, but then this whole group here is like, they're paralyzed. What to do? What to do? We don't know. You get that feeling? We don't know. So there is a huge lack here, a lack of competency. It turns out that when we teach our young residents in puncturing veins, they learn it in real patients, in real sick patients. That's a difficult thing to do the first time you're IV access. So if you just look to principles of learning, when you have to learn a complex thing, you focus on that single complex thing. So they can only learn to puncture, but not to see the kid around. You cannot learn this at the same time. That's too complex. That's two complex tasks at the same time. So we teach our young professionals to ignore the patient from the very beginning. That's how we teach them. So here is a challenge for all of you involved in medical teaching. If we want to change this, we want to close this gap, we should add competency, skills, knowledge, how to deal with a frightened child. And this is so far a far too high challenge. Symbolically, I put him there. There is then the whole concept of time. Do we have time for this? Yesterday, the day before in the hospitals here, we don't have time for this. Most kids you can gain trust within 2 minutes. So it's not a matter of time, and you will save time afterwards when they collaborate with you. But there's also this dilemma thing. sometimes you have to hurt children because there is an urgency. So it's not a matter of black-white, of course. We all know that. We have to put the IV antibiotics in now. This child is sick now. Do we have time for comfort or not? So we know that dilemma. So we have to discuss dilemmas with each other and make choices. It's a matter of collaboration and logistics. I was informed last few days that nurses sometimes want to do it well, but then the doctor says, no, we do it now. This kind of relationships, if you don't have the same goal, you destroy trust, not only to the child and the parent, but also within the teams. This is relational. And this one is a great one. There's real proof, even with functional MRI scans, that when we as professionals are dealing with a painful procedure in someone, we close our empathy. We become transiently empathic blind. We just do not see it. So imagine that that means that we as doctors are not able to see how much pain we cause in our patients. We are blind for that. Unless you film it, like the boy I showed you, probably you were shocked to see what happened in that emergency room. But if you would have been in that team, probably you would have not noticed what was happening. So here is a call for going beyond that blindness. So I've been working with my team and with others, diving into how to solve this. We could try to measure pain and measure anxiety in procedures, but I don't like pain scales. I don't believe in pain scales. I imagine that someone would put a scale on me the way I'm in love with someone, from 0 to 10. Oh, today I'm on a 7 in my feelings for you, for example. And for you, maybe it's a 6.5. Who has invented pain scales and anxiety scales? Why a number? Because we're addicted to statistics maybe, or whatever, to prove. It have helped us a lot in the beginning, but now in dealing with patients, is a 6 less than 8? Yeah, mathematically it is. But does that change in what we are doing? That's the question we need to ask. I love the numbers for science, but don't use them in your daily clinic. Don't say the patient has an 8 today, so we do this. No, look, touch, interact, read the cues qualitatively, share it with others, but don't make these things numbers, please. That would be a great lesson to take home if you wish. So, oh wait, I go back. What we have done is not measuring pain, but we've started filming. We film our own practices, the successes and the failures, and actually have started focusing on the successes. And the one question we ask, did we establish trust in this child or not? And what made it that we created trust in that child? So we had a positive focus, a wellness focus, so to say. And I'm going to show you one video as an example. We have made hundreds of them, and it's an ongoing validation process. And out of that movies, we tried to get strategies that professionals could use to use in daily practice. That's the whole field. So I'm going to show you this video. You see, at the left is the patient. You had figured that out, that at the left the patient is. Yeah, okay, thanks. At the right is one of our specialized nurses. She's a procedural sedation analgesia nurse. We call that PROSA nurse. And she's meeting the child here. This is a girl that actually needs blood sampling every 6 to 8 weeks because of a certain drug she's getting. 4 or 5 years old. And she was referred from another hospital because of severe needle anxiety. This child needs blood sampling for the rest of her life. So look for the learning perspective. If we can make her trust us, we will help her to grow up and at a certain point do it completely herself. That's the goal, that's the vision. It's not about just taking pain away, it's about maintaining trust and keeping her in a relation so that she can learn to deal with her disease. Because at a certain point, that's what she needs to do. And I'm just showing you what we're doing, and then we are going to deconstruct that. So you see here the EMLA on her hand. This is the meeting. They match each other. They know each other. You see how close they can come. It's a very short interpersonal distance. They play a bit, and then they come into our procedure room with the child life specialist. We have this great lamp, light standing here. There's the father, And look, it's only comfort. There's no needle around. We check, she will get nitrous oxide sedation. That's the strategy we used at that time for her. And so before we start, although she knows, we check whether she understands all the things. We desensitize her for the things together with father. So it's one playful moment. And look now she's getting under nitrous oxide sedation. A very close matching. They are matching each other. There is a single voice system. Only they interact. Look, she's partly awake. And now we start going to the procedure. Here is the comfort zone. And here you hardly see it thanks to the lights. But here, look, there's the comfort zone. And now the professional is starting the blood sampling. She's not reacting, but look, she's awake. She's completely focused on this professional, supported with some nitrous oxide inhalation. Now the procedure is done. So she wakes up together with the father around, who was around all the time. So there was one friendly, pleasant meeting actually. And by the way, in the middle of the meeting, there was a blood sampling. You see, it's not the blood sampling, it's about the meeting. Then she gets her gift. She can choose a small present. And here's the child life specialist. And you'll see what she was doing at the end. So they close the door, the box. And now father asks, you have been punctured? No, I have not been punctured. But the child life specialist said, yes, you have been punctured. Look how successful it was. It's done now. This is the learning moment. Because she goes home with a certain memory in mind. And here she takes the mask with her, you see. She's providing nitrous oxide sedation at home to her siblings. And with that mask, she comes back the next time. So that's one meeting we have with this girl every 4 to 6 weeks. So let's deconstruct this. This is not a trick. In each child, this is different. So don't go home and say, that's the way we should do it and do it in all patients. You will not be successful. So we discovered that it is crucial before you start to think about yourself, what does this procedure actually mean to this child? For some children, it's like, oh, please do it. For others, it's like a drama. So it's individualized care. Reading the procedure. What does it mean for this child? A second thing, of course, is imagine that it was not this girl, but one of the others I showed, the strategy would have been completely different. So don't make one protocol for your blood sampling. It is individualized care anytime. Then second, is this procedure really needed? So many children get blood sampling or IV, whatever, because that's the protocol. Oh, there's a pneumonia, after 3 days the IV is out. We have a protocol that it should be 7 days IV. Come on, there's evidence that after that time you can go to oral. So don't puncture anymore. So there's so many opportunities not to do the procedure. First, do not harm. So the prevention is a very important strategy to consider at any time. And actually, others have mentioned this as well. And then you have the psychological strategies. And I want to make a difference between preventing fear and navigating emotions. Preventing fear is essentially a matter of predictability, making sure that child and parent know what's going to happen on their level. We don't explain to this girl, yes, you will get a 24-gauge needle in your left umbilical vein, and we put Emla to take the pain away. No, that's not the information we give. We give her the information about the experience she's going to have. And mainly here, the comfort-directed communication, verbal, non-verbal. You mentioned parentese, which is an international language, especially in infants. Has anyone had a course in parentese here? No. It's crucial. The speech, your tone, how quick you speak, that's dependent on the age of a child. You have to learn to modulate that. It's crucial. You were saying about Kentucky Fried Chicken. So this is your K here at the left, kindness. Just enter as a kind person. I'm interested in you. We've been filming professionals entering the room and analyzing what they encode. That's a drama they encode because they come from the previous meeting, full of stress. Here I am. Yes, I have no time for you. No, wait a moment. Step back. Use the door to reflect. A mindful moment. I'm ready for you now. Now my face is open. That difference makes it all different. Whatever you do, the child will respond on. The parent will respond on. So this non-verbal thing, being kind, here's okay, I will come back on the F and the C as well. Because they are here. Navigating emotion from fear to trust. That's redirecting the focus. If you're close to your mother, I'm always playing with you here, but you're close to your mother, I want you to go to me or to put your focus somewhere else. I do that with a playful interaction. Here's your fun part. That's the fun part. That's the playing. Has anyone had courses in learning to play here with children? No. What a missed opportunity, because that's the language of children. If we claim that love and play is important, we should learn that. It's a serious thing, playing, age dependent. So let's organize courses for, maybe that's a topic for the next meeting. Let's play. It would be the title actually for the symposium, isn't it? Eh? And then what was the last one? The C? Curiosity. If you want to direct the focus, if I want your focus, I have to arouse your curiosity. So playing with curiosity is crucial. So I loved your KFC. It's actually on this slide. Then, of course, other strategies take the pain away. In pediatrics, it's often, no time. It has to work 60 minutes. Oh, time, there's always time. There's always time. Just like there is in the universe, there is love, I think there's also time. I've been working a while in an African hospital, and one day an African doctor said to me, you know what the difference is between us Africans and the Western world? You have the watches, but we have the time. And I love that. So let's think in time, not in a productive way, but just a time that is always coming. But the time for this kind of pain-killing strategies, I come back on that in a minute, for neonates. This is this buzzy thing. That's this vibrating tool with some cold pack around, can take pain away, but you can just use that using your hands as well. Using tactile stimuli above a vaccination will take the pain away, using that gate control theory. Then, of course, you have sedation. Sometimes it's sedation, but many people think that sedation will do the job. If you sedate a child that is not trusting you, you get a disaster. So it's always about the combination of the different strategies. And then the logistics, the collaboration and the setting. As you have seen in this video, you saw how the whole setting was comfort versus procedure. You have to organize that. If the doctor who comes in for the puncture does not know your strategy, he will disturb the whole setting. Because he's there, he wants to meet the child. No, don't speak, just do the puncture, get out immediately afterwards, and afterwards you can talk to the patient. You have to organize that. And of course you have to take into account the program of the doctor. So it's a logistical thing. Many things here are actually logistical challenges. Have you ever been trained in the logistics of performing a procedure? Do you do scenario training in how to do a procedure? Maybe for intubation and resuscitation, but also for an IV access? No, you see, so do that. It's simple, especially if the child is on the lap of the mother. That's something you need to practice, to learn, to make scenarios. So here's a comfort zone, you see, quiet, comfortably, close, interaction with one person, professional proximity, you mentioned, instead of distance, one voice principle, and then you have the procedure zone where there's whispering, limited light, careful touching. This is another example. Here's a young child of only a few months old, recovering from bronchiolitis, still on the high-flow nasal cannula, and the child needs prolonged antibiotics. So we are giving one of these peripheral and central venous lines, ultrasound-guided. The mother is performing the sedation with a bottle. And look where the professionals are sitting here, on the small chairs for the children, not in the bed. So it's the procedure is adapted to the child, and it's not the child that is adapted to the procedure. Different perspective and an excellent result in this case. Is that what you should do in all infants? Of course not. It's tailored according individual capacity of the mother, the child, whatever, the team, technical challenges, etc. And then finally, what this child life specialist did is the closer of the meeting. When we do a procedure in a child, we usually run away after the procedure. The needle is done and we say, it's done, and we run away. We sometimes start saying it's done when it's not done yet. You know that? It's done, the child starts fighting, it's done, it's nearly done, and then we start cheating. But usually it's done and then we run away. But for the child and the parent, it's not done at all. It's for them not about the needle, it's about the whole encounter, the whole meeting. So here is your crucial moment to take a few minutes to debrief, reflect, and to learn. This is the learning moment for the child. Here she will build her memory for the next meeting, for the next encounter. So, and if imagine this child had suffered pain in a certain way, this is your unique chance to comfort, reset, normalize, and to maintain trust. If I hit you and I run away, we cannot rebuild our relationship. So here's a unique opportunity to recover, to save actually the trustful relationship. So this is our 7 strategies. And we call that so far the 7P framework of comfort strategies. This is not a protocol. This is strategies that helps you to provide comprehensive care. It's all together, and it's a game you play. You say, okay, this will be very painful or very frightened. Let's go to sedation probably. But wait a moment, sedation, this is a child with Down syndrome. Sedation is more tricky. So maybe think about prevention. Is it really needed if that's the condition? So it's a framework to help you reason. And if you figure out an 8 or a 9th P, please let me know, because then we enrich the model. It's just a framework to help comprehensive care, education, training, and implementation, and especially scenario training. These are things you can train with your team, how to set the stage for a medical procedure in a child. And then, of course, and now I want to warn you again, I'm not a neonatologist. So I question myself for my last 5 minutes, could this model be useful for you as well? I don't know. I don't know. Okay, thank you. That's my question for you. Could help. So let's dive a little bit in it. And these are mainly open questions. This is not a sacred model and you can just use it. I don't ask money for it, not at all. So reading the procedure, what does this procedure mean to this child? You came with a lot of evidence on the impact of painful procedures for infants. And I was actually struck by this recently published paper and for me it's hard to read the whole, I understand the context and the methodology, but if you read these papers and many other things that I found in literature, the immediate negative physiological effects, the altered pain processing, the pain sensitivity, the connections with the amygdala, the disturbed stress response. Wow, your job is terrible. To take that into account, that must be extremely difficult. You know, in Belgium, where I grew up, in the farms, they had these tissue hanging at the doors to catch flies, like a glue. There was you have these things. It's like you take it out, it's hanging, and it's a glue-like thing, and each fly that flies around sticks to it. That's how I see neonates. Anything that you do to them sticks and stays there. That's a huge challenge for you. These young infants, up to even 3 years, they're so vulnerable. So what a challenge for you. So yeah, it means so we could connect this with prevention. So I was very happy with the recent evidence in newborn at-term infants who come in with fever but without severe sickness, that oral antibiotics are as effective as intravenous. Wow, that opens the options to prevent a lot of painful procedures. Or the evidence that children from diabetic mothers might need less glucose control than we used to do in our older protocols. So that's maybe 25% punctures less. So there might be many other options where you can actually prevent what we are doing. Central lines, what you do, of course, prevent a lot of punctures afterwards. So yeah, there's an option for prevention. And then the psychological strategies, of course. What's up? What are the options here? So let's put the list again. The KFC put it back on the screen, and I was wondering, what would I do with what I know from children beyond 0 years old up to older children? I would certainly focus on desensitizing. When I would touch a young infant and I do something, I think I would hold its hand for like 5 minutes, so that they get used to it. That when they are positioned for a procedure, I think I would wait again. I see these vulnerable infants as very slowly processing species or human beings. So I would desensitize. I would use verbal, non-verbal and parenting in all children. I would want to learn how warm my hand would have to be to put on the head of a child, in what position when I have to puncture, or when someone hold the child in that way while I do something else. And maybe if I have to puncture, what we see in older children, if I distract you for a puncture, and I enhance the distraction just on the moment of the puncture, I actually take your attention fully away. I don't know whether that would work in an infant. You certainly know that, but I would do that. I would probably, my hugging, I would make it more intense just on the moment of, and not just like a formulaic mechanical thing, but be in line or be in phase with what's happening. And we should all follow courses in parentese. And the international thing is, interesting thing is, it's an international language. So you can use it, you can even use it in your colleagues. What about calm me down now? That's really helpful. So it's international, it's everywhere the same. Distraction, I mentioned it. So let's think about skills that we can add to the way we work. Then pain killing, again, many uncertainties. If you go to the meta-analysis and the systematic reviews, what about EMLA? I'm happy you mentioned EMLA, because in some NICUs, I hear they don't use it because it's methemoglobinemia, or it might cause vasoconstriction, which is, by the way, nonsense. If you leave it long enough, you get vasodilation, or it's or no time, whatever. The right dose, how much can you put on? So let's make guidance on the structured use of EMLA. How much? That would be a question for me. Could we use the gate control? Would it be intact in an infant? Could we use touching just above the needle to use the same mechanism? Maybe that's a question for me. Is that intact in an infant? I don't know. I couldn't find evidence, but you certainly know. Then the whole non-nutritive sucking, facilitated tucking and swaddling. I've been watching what happens in certain NICUs, and it's happening mechanically. Put in the sucrose. No, it's about this. The swaddling, the tucking is full of love. Otherwise, it's not working, I think. And so, do we train ourselves in a mechanical way or in a loving way? And then about opioids. Yeah, you mentioned opioids. It's all. What is the right dose? How much? When to give prior to the procedure? I don't know. When we give fentanyl in an older child, we wait 5 to 10 minutes for the effect, because that's the pharmacokinetics. If we use it intranasally, we wait 20 minutes. I don't know what, if I would give morphine, when is the right moment to start your procedure? What I see in many ICUs, we give the fentanyl and we start the procedure. So could that be improved, that part? But for pain, there is also a lot to win in how to process, how to organize the logistics of what you're doing. Then I think the post-procedural care, do you do that after a procedure, that you take like 10 minutes to hug the child again? To help to regulate the emotional moment for the child? In older children, it's crucial. But what to do in an infant? And of course, the psychological strategies to be mentioned are crucial in the pain strategies. And then final, procedural sedation. Yeah, what's safe? Could you use how to remove a chest tube? When I see that in children of 3 years old, that's very painful. How to remove it? Should we use fentanyl or morphine, or should we use propofol together with what's safe? What's the good drug? I don't find much guidelines on that. And maybe the evidence is not there, but maybe we can, even in the field of uncertainty, we could construct a kind of consensus and then measure it and study it and evaluate it. So what about neurotoxicity? Which drug with those? I really don't know. I'm sometimes asking a NICU, and I really don't know what is safe to be used. So in a summary, I wanted to show you that beyond all the biological evidence that we have heard, and the evidence of the importance of kindness, fun, and curiosity in enhancing happiness, the same principles can be translated in professional standards, in way of working, in frameworks for teaching ourselves. And we are all, no one knows exactly how to do this. This is but that's why it is such an interesting learning experience. And this is my final slide. If you want to visit Maastricht, which is, of course, it's the oldest town of the Netherlands. It's 2,000 years old. It's a beautiful small city. We have the best restaurants of the Netherlands. Be welcome. This is our conference in early September, and we will have a whole morning about the edges of childhood, being the infant and the adolescent. That's another a little bit ignored patient in pediatrics. So there is neonatology, neonatal pain around, and you'll see, if you check the program, you'll see that is a comprehensive program on this field. I thank you for your attention, and now it's Fika. Yeah. Oh yes, there might be the questions, yes.
So thank you so much for this engaging lecture, interactive. At least we had a lot of interaction.
Yes, we had,
yeah.
And I loved it. He interacted with me as well. No, yes, of course we did.
So please all, I don't think you had any problems at all in translating what was talked about here to the neonatal community. So please come up with comments. Total silence. You were so crystal clear.
Can I ask your opinion on the gate control or any other that would be?
So the inhibitory interneurons in the dorsal horn of the spinal cord, and the descending inhibitory fibers, they don't develop before 32 weeks. Mm-hmm. So and the sequence of how the descending inhibitory controls from the brainstem are growing down into the spinal cord, making connections. That sort of follows a developmental timetable. Mm-hmm. So those connections are formed until late in gestation, probably around 36, 37 weeks. Before 32 weeks, you don't have the inhibitory interneurons there. So there is, you cannot use the buzzy thing or for the gate control. Below 32 weeks, it's not. No. And then it proceeds from rostral to caudal direction, the length of the spine.
Okay, thank you for that's interesting. Thank you.
Lena?
I can talk loud.
But they don't hear you, I think, at home. That's correct? You need a microphone to be...
Thank you very much. My name is Lena Hellström-Vestas. I'm a neonatologist, and I'm involved in teaching of medical students in Uppsala mainly. And I just wondered, I thought this was a great lecture, and I just wondered if you have any movies of this with teaching films.
Yeah, we do have. Yeah. We are now building a whole library of movies. But I work a lot together with Baruch Kraus. Maybe you know him. He's an emergency physician in Boston Children's Hospital. And actually, we were together, the two of us, the last few days here, lecturing in the pediatric community. And he has published in 2019 a great paper in Annals of Emergency Medicine. If you go there, Annals of Emergency Medicine, Kraus with double S, you'll find, and the title of the paper is Managing the Frightened Child. And this is all about the very first meeting. You enter the room. What can you use to desensitize the child for yourself? How do you arouse curiosity? Because curiosity is a great thing, but how do you get that curiosity? And then how you integrate your physical examination in that. He gives a framework, and below on that paper, there are like 10 videos. And if you have a registration via your library, you can download them and you can actually download the videos. And it's great teaching material to teach to students, especially those who go to the pediatric ward for the first time. And they see a child and never seen a child. They think, what kind of animal is this? And I have to do a physical examination. But actually, you should learn to play with them first and to interact, and then later on. So these movies are available and downloadable. There was another question.
I think it's me, yes. My name's Beverly. I'm from University College London. I'm not a doctor. I'm a therapist.
But that's good. That's okay.
I work a lot with with the doctors, and you've mentioned how often they don't have the opportunity to do the procedures, they're learning on the job, and things like lumbar punctures, which are really complex, they might not get many opportunities. Have your trainees, when you've worked with them, had any thoughts about how they can still have the relationship with the person providing the comfort to, let's say, a younger child, while still working on the procedure? Because what we see is we have somebody providing comfort, but then they need to still have a relationship with the person doing the procedure to say, you need to pause, you need to... Have you had anything from your trainees?
Yeah, we are now, one of my PhD students is using video reflexivity ethnography, that's actually diving the real practice by using video, in seeing how teams work together to guide a child through a procedure. Because there are actually different layers of complexity here. Performing the procedure is a complex thing, at least in the beginning. So that part should be learned in simulation settings or on the operation room or under deep sedation. There should be in our training programs a system where people can just focus on the procedure. Then there is the connection or the collaboration with the others involved that deal with the comfort, like you've seen in this video. That's another skill set, because if I start my puncture and you are providing, for example, nitrous oxide sedation, I have to look at you. Can I start? No. Yes. When I start, you should attract the attention of the child, so to bring the consciousness as far away from what's happening at the back. That's a collaboration. If I hurt the child and you see that, you should be able to communicate to me, and I should be a follower at that moment. So these are actually crew resource management skills that we know from resuscitation training. It's exactly the same principles, but we should practice this. And then there is the highest level, that is that you do the lumbar puncture or the venous sampling or the suturing, and that you interact yourself with the child and the parent, that you are in full control. Because sometimes you're alone, or you're assisted by someone who is not able to do anything, who is just keeping the tubes or whatever. That's the highest level. And I think the training programs should follow something like this, because each of these are complex professional tasks. We think collaboration is simple. Have you ever been trained in collaboration? Collaboration is very, very difficult. So yeah, that's what you can say about this. Yeah. Yeah? Okay.
So thank you very much. These 2 hours have been extremely engaging. Round of applause for Piet.